Yeah, thanks, Kusum and Amila for inviting me. So today's talk is how to evaluate a patient who comes and asks for refractive surgery. Okay, so there are two cases of mine who just came to the clinic asking for refractive surgery to see without glasses. So one guy has -5, 125, roughly the other one has a -150 with a high cylinder. Well, how will you proceed? So you, as usual, you take a history, you ask the patient why he wants surgery done, LASIK done, then take a history, do an ophthalmic examination, and then do some investigations. So patient expectations, it's important to see how old the patient is. Generally, we don't do under 18. Minimum age is about 18, preferably 20 to 40. People who want to see distance without glasses are mostly the candidates for refractive surgery. So a person who's 38, close to 40, who comes a low myope, who wants refractive surgery, you have to tell them exactly that if you do refractive surgery, your near vision will get affected. So you explain to them that you'll need reading glasses instead of wearing distance glasses. So these are things that you need to explain to the patient. And then you do a proper, complete examination, whole eye examination. Look at the cornea, make sure that there isn't anything obviously wrong in the cornea. No cataract. The person may be having a cataract, and that can cause refractive error. Normal macula, and there are no peripheral degenerations. So do a complete examination. These are just a few. Well, then the investigations, we look at the pachymetry, the corneal thickness. We can also look at the corneal epithelial thickness. Topography, that's looking at the surface. And tomography, the elevation maps. So methods of pachymetry, there are so many, ultrasonic, optical, but what we use mainly optical, the OCT, and Pentacam, which is based on Steinflug imaging. So the case 1 patient has, this is the pachymetry analysis, thickness is about 530, 570 I think, and the epithelial thickness map looks pretty much normal. The second patient has corneal thickness of about 440, so it's pretty thin. And in the epithelial thickness map, you can see that there is a epithelial donut pattern. So this is the area of thinned out epithelium corresponding to the keratoconus elevation. So this is characteristic of keratoconus. So this is the epithelial donut pattern, grade 1 to 4. This is indicative of keratoconus. Then you do topography, looking at the corneal surface. You look at, there are two methods of doing reflection based, that's the Placido disc technology. And then the elevation based, we have the wavefront technology and the Steinflug imaging. Placido based systems are good, but the advantages that they can get the images pretty fast, an accurate measure of the anterior corneal surface, but you cannot look at the posterior corneal surface and no peripheral data is available. So this is a Placido disc-based topography, and you can see some patterns like this, pellucid marginal degeneration, the crab core pattern, and here in the other one, has a skewed radial axis, a symmetric bow tie pattern with a skewed radial axis. So there are two types of topography maps, the sagittal, the axial map, and the tangential map. I think we'll leave the details aside. And then you have the wavefront analysis, which gives a better picture actually. So this is a wavefront based topography, which is from the case 1, has a symmetrical bow tie with the rule astigmatism, and the other patient has a truncated bow tie, though it's slightly asymmetrical bow tie, truncated appearance, again typical of keratoconus. And this is a picture of a wavefront analysis topography which has an asymmetric bow tie with a skewed radial axis. Inferior steepening on one side and the asymmetrical bow tie with inferior steepening in the other eye. So tomography, there are many types of tomographers machines available, but what we use is Scheimpflug imaging. We had at Navaloka earlier the scanning slit laser, which was laser technology, which was the OBSCAN, but now what we use is the Scheimpflug imaging, the Pentacam. That's what we use for pre-op assessment. Well, the tomography systems can look at anterior and the posterior corneal curvatures. It can look at check the pachymetry. You can check the thickness. It can also check the anterior chamber depth, which is important for ICLs, and anterior posterior floats. That's the elevation data on the anterior and the posterior surface. And also, it can also measure the corneal and the lens opacification using densitometry. So these are the users of a tomography Pentacam system. So Pentacam, as I said, is a comprehensive anterior segment analyzer which does these 5 functions. This is a tomography report, a basic Pentacam report, which has 2 parts. This is the first page, which has on the left-hand side are the corneal parameters, and the right-hand side has 4 maps. It's called the 4-wave refractive composite map. So on the left-hand side are the corneal parameters. So this is the corneal parameters. It looks at the corneal front surface, corneal back surface, and then the grade C is the pachymetry values, and there are some values which are used in IOL calculations. So the anterior corneal data, do you have a pointer? This is a pointer? No. Yeah, can't this thing, no? Okay. So here look at the quality, just make sure that the quality is okay, and look at the Q value. Now Q value is the spherical aberration. If it's a sphere, the Q value is called 0 in the middle. So this is a sphere which will have a Q value of 0. Prolate corneas are steep in the center, flat in the periphery, which is like a normal corneal surface that we get in young people. So less increase in effective power in the periphery, that will actually give you a Q under 0, a minus value Q. And oblate ones which has a flat center, which happens after refractive surgery, will be an oblate surface which has a flat center and a steep periphery. So prolate surfaces are normal, but hyperprolate surfaces are also abnormal, and this can happen after refractive surgery in keratoconus as well. So Q value, normal value is about 0 to minus 1. If it is more than 0, it's an oblate cornea. As I said, it happens after myopic photoablation. Over minus hyperprolate corneas, mainly with hyperopic photoablation or in keratoconus. So you look at the keratometry values. It's over here, the K1, K2, and usually it has to be less than 47. So that's the norm. And if you have a 47 to 50, between 47 to 50, it's suspected keratoconus, and above 50 perhaps is abnormal. So then you have the next column, looking at the pachymetry values. And this tells you the pupil center, the thinnest location here, the thickness at the thinnest location. So look at that. If it is less than 470, it is abnormal. So you should have a above 470 value. and the y coordinate at the thinnest point. So how far displaced inferiorly is this thinnest location from the cornea center? It has to be less than 0.5 millimeters. So if it is more than that, that is also a feature of keratoconus. So look at the figures. 47 to 50 moderate risk of ectasia, 50 above 50 high risk, and thinnest location, thickness 470 is the minimum normal, and here it has to be less than 0.5 millimeters. Then you look at the corneal maps. It has the anterior curvature sagittal map, that's the topography report, and this is the anterior elevation map, the posterior elevation map, and the Pachy map. Anterior sagittal map, you can see the corneal topography, as I was mentioning earlier in the topography. You'll see all that, the steep axis it will show. And then you look at the 5 millimeter circle, and two opposing points on the 5 millimeter circles are useful to assess for keratoconus. So two opposing points, superior and inferior, on the 5 millimeter central zone. If the inferior point has a higher value, the difference that is allowed is on less than 1.5 diopters. And if the superior value is high, you can allow a 2.5. If it's more than that, that is indicative of ectasia. Then symmetrical bow tie patterns represent regular astigmatism. It can be with the rule or against the rule. So these are symmetric values. So you can see normal symmetrical bow tie, a round pattern or an oval pattern. These are normal when the Kmax is less than 47. These are seen in less than, round and oval patterns are seen in patients who have less astigmatism. So if you have high astigmatism, with the rule will appear like this. Against the rule is somewhat like this, and an oblique one. These can be normal if the Kmax is less than 47. Okay, so these are asymmetric patterns. You can see there is inferior steepening here, superior steepening pattern here. So this is abnormal if the two opposing points are more than 1.5. Here, if it is more than 2.5, it will be abnormal. Here it's an asymmetric bow tie. You can see it's a bow tie, but asymmetric with superior steepening. And here is a condition where asymmetric bow tie with inferior steepening. Now, skew shapes, if the two axes are not aligned, symmetric, if the angle between the two axes are more than 21, it is abnormal. Normally, it has to be less than 21 for you to call it a symmetric bow tie. So this is a symmetric bow tie, but with a skewed radial axis. And here it's an asymmetric bow tie with a skewed radial axis. So these patterns are, of course, highly suggestive of ectasia, a butterfly pattern, a crab claw, vertical D. All these are indicative of keratoconus, highly suspicious of ectasia. Then you look at elevation maps. This is where you have the elevation map, elevation measured, and then you have a best fit sphere, a perfect sphere that best approximates the corneal shape on average. It is to fit the central 8 millimeter zone. Anything above that will be in red. So this is, if you imagine this is the corneal surface, you draw a best fit sphere. So anything below will be blue or green. Anything above will be orange and red. Now, these are the figures that you should be looking at. In a myope, we are mostly looking at myopes in refractive surgery. If this figure is in the central 5 millimeters, the 3 millimeters is more than 8. In myope, it's abnormal in the front surface, elevation front. And the back elevation, it's over 18, it is abnormal. And the difference between the front and the back should be less than 5 microns. So the enhanced BFS is here. What happens is you have a elevated area, by incorporate the abnormal portion of the resultant BFS best fit sphere, and elevation between the BFS and the cone is less. So you draw a new best fit sphere, leaving aside the central thinnest 4 millimeter zone. So it will be at a lower level, and this will enhance the elevated area in a picture. So enhanced BFS will further emphasize the conical region. So elevation maps, you can see that these are normal. There's a symmetric hourglass, isolated island. There can be asymmetric tongue-like extensions, and there could be irregular corneas, and keratoconus, it may look like that, irregular corneas. But these are normal. Then in the best fit sphere enhanced picture, there you look at the standard elevation maps. Then you have enhanced exclusion map, leaving aside the difference. You have to draw a new best fit sphere, and this is the second picture. So it will enhance the elevated area, and the difference between the two pictures is shown in the third difference maps. And there are some figures that we look at. If in the front surface, if it normal, it has to be less than 5. In the posterior, it has to be less than 12. So if it is more than 7, it gives a red flag. In the posterior surface, if it gives above 16, it gives a red flag. So pachymetry maps, again, you look at the pachymetry maps. As I said earlier, look at the thinnest cornea thickness and see whether it is displaced inferiorly more than 0.5. And normal difference between two opposing points on the vertical meridian at the central 5 millimeter should be less than 30 microns. That is not there, then it's highly indicative of an ectasia. So these are abnormal shapes on pachy maps: dome-shaped, bell-shaped, which is seen in posterior pellucid marginal degeneration. Keratoglobus will look something like that. Then you look at the corneal thickness profile, which tells you how it thins out the cornea, how it thickens when it moves from the thickness enhancers, when you move from the center to the periphery. So it has to be within these lines. So this is normal, but if it is a quick slope, if it drops down, then it is indicative of keratoconus. If it has a S shape also, it is suggestive of keratoconus. A flat curve happens when you have edematous cornea, and in pellucid marginal you get a red line which moves upwards because the inferior thinning is there, so it will move upwards. Then you have look at the D value. The D value is the standard deviation from the mean. There are 5 parameters we look at: the front elevation, the back elevation, the pachymetry progression, the thinnest point thickness, and the thinnest point displacement. So look at these figures, and if all are white, then you have very little risk of ectasia. And this final one is the composite of all these figures. So if there is a red, it is indicative of ectasia. So to summarize, red flags for corneal ectasia. So these are the patients we do all the tests, and then if there is any of them, we have to be very, very careful in performing refractive surgery. So sagittal map, Kmax over 47, any asymmetric bow tie where you have a axis of more than 22, IS difference 5 millimeter zone. If it is inferior steepening, it has to be, if it is over 1.5, if it is superior steepening, 2.5, and a Q value over -1. Anterior elevation maps look at the myopia over 8, and posterior elevation map myopia over 18, and pachy maps the corneal thickness less than 470, and the thinnest point Y-look coordinate displays more than 0.5 is suggestive of ectasia. So looking at this patient, the first patient, you can see that all these are perfectly normal, and this is normal as well. You can see all these D values are in the white range. And then next patient, you can see the final one which has all red flagged, and this patient obviously has keratoconus, and you should not think of doing refractive surgery for this patient. Thank you.